All right, guys, so we're still in our cardiovascular section and we're still here with Mr. Chuck. It's been a couple of years have gone by, and now he's like a big accountant, a big CEO in a healthcare administration, and he comes in today for his yearly check. And what we see here is that his blood pressure, despite what we had already done, is now starting to kind of creep back up into the no-no zone. So for this patient, this will probably be the most appropriate place for us to start thinking about putting on an antihypertensive in addition to the medication therapy that he's already on. So I go back to my handy dandy little chart. Again, I don't leave home without it. I've got my JNC algorithm sitting here and I'm looking. Okay, so he's black. So, all right, if we put him on a thiazide already, what's the next logical step? And for him, it'd be a calcium channel blocker alone or in combination with something else. So we're going to keep moving forward. We're going to learn about all these different classes of antihypertensive medications and how we can use those in our practice. So here's just a breakdown of all the different classes of medications that we can use to actually control blood pressures. I put the most common ones on the right-hand side, and then again, we have this big scary drugs. The reason why they're big and scary is because these medications are more likely to cause orthostatic hypotension. So let's spend some time getting to learn about our first category here, and those are the drugs that affect our renin-angiotensin receptor system. So with our renin-angiotensin system, we get 4 different categories of medications. We have our ACE inhibitors, our ARBs, our renin inhibitors, and our aldosterone activities. Basically, what you need to know, these guys work all out here in the periphery to decrease peripheral vascular resistance, which allows the blood to flow in and out a lot more easily. You need to take some time to really kind of study this slide. This is kind of like a basic breakdown of how this is produced. So number 1, hormone renin is released from our kidney, and it says, hey, everyone, we need to tense up. Well, angiotensin comes out. The ACE converting and the angiotensin converting enzyme changes it from angiotensin 1 to angiotensin 2. And then it goes to the kidney, causes renal constriction, which decreases the renal blood flow, which increases our blood volume, and boom, we get an increase in our blood pressure. So when we talk about medications that are ACE inhibitors, they're preventing that little triangle, the little blue triangle, the ACE inhibitor enzyme. If we talk about ones that are ARBs, they actually block angiotensin 1. So we get a little different effect with each one of the medications classes that we'll be talking about. They work a little bit differently in our pathophysiology in order to produce their effects. Guys, I'm going to tell you, we use a lot of renin-angiotensin drugs in our practice. If you're sitting here thinking, I don't need to learn the patho, I will tell you that there are nursing instructors who will dog and pony you until you can just give them this like you would give a baby a glass of milk. Like, you have just got to be able to regurgitate this stuff every single time. So again, spend some time. I've given you some additional resources in this chapter for you to learn this system. Make sure that you do. The first set of drugs that came out of this were called ACE inhibitors. Fun fact, the ACE inhibitors are actually kind of based off of Brazilian pit viper venom. And so we found out that they were really great for blood pressures. The first couple of times that they figured this out, it actually killed someone. But in controlled doses, the ACE inhibitors do have a huge role to play in our patients with high blood pressure, patients with congestive heart failure. They work really, really well. Another one of these fun slides that tells you all about ACE inhibitors. Hopefully these wonderful visuals will help to stimulate your brain next time you go back to take a test or you're working with these drugs. Remember, they all end in pril, P-R-I-L. So an ACE inhibitor, again, I kind of already alluded to this. They have lots of great usages. Our therapeutic one for this is going to be enalapril. As with any medication, the first time that we give it, we can get this first dose hypotensive effect. So basically what happens is you give them a dose, and within 30 to 45 minutes, their blood pressure drops back down to normal, and they get really dizzy and they can pass out. So we always warn our patients to change positions slowly. If we're in the hospital and we're given the first dose of medication, I always tell my patient, I said, okay, I've given your first dose of blood pressure medicine. Now what I want you to do is I want you to call me before you get up. Yes, I know that you're perfectly capable of getting up on yourself. This is for your safety. Patients who take ACE inhibitors also sometimes have a cough. And the reason they have a cough is because of a release of bradykinin. The bradykinin causes this like dry, irritating, throat tickling kind of cough. And so these patients, sometimes that will be the one thing that irritates them the most that will have to change their medications. Absolutely positively, we don't give this medication during pregnancy. One of the other weird things that happens is called angioedema. You can have patients who have who will develop angioedema even after they've taken the medication for days, months, weeks, or years. We had one of our nursing instructors, she had taken lisinopril for the last 5 to 10 years. One morning woke up and started talking like this. Sounded like she had a sock stuck in her throat. And that was the formation of angioedema. Inside of her mouth all swelled up, the whole 9 yards. They had to take her off of it. That's a severe reaction to that. These medications are known to cause hyperkalemia, so always make sure that you're following their potassium levels very closely, looking for that 3 to 5 range to be within somewhat of normal limits. These medications really aren't drug interactions. These are really issues with increasing the medication's potential. So if we're giving an ACE inhibitor and we're also giving a diuretic at the same time, we would expect a greater drop in blood pressure than we would if we were just giving an agent singly. Okay, so the same thing, if we're giving them an ACE inhibitor and a calcium channel blocker and a beta blocker all at once, we're going to get a bigger bang for our buck. So we need to make sure that we're very cautious with those patients, that we are monitoring them, that they're not becoming hypotensive because we're giving them too many agents at once. If a patient is taking an ACE inhibitor and they're also taking potassium chloride, there is a chance that they can have an increase in potassium. It could lead to some dangerous side effects. With lithium is one of our medications that we use for bipolar depression, has a narrow therapeutic index. Any medication that has a narrow therapeutic index doesn't play well with others. So when we take an ACE inhibitor and lithium together, it actually raises the lithium levels and can make the patient toxic. NSAIDs may reduce the effects of your antihypertensive medications. So just be thinking about that. Remember, ACE inhibitor kind of works in the kidney to prevent the ACE from going to from angiotensin 1 to angiotensin 2, which ultimately prevents the renin from being released. So it's kind of a kidney function. Remember when we talked about NSAIDs? NSAIDs kind of have this known like naughty thing that happens with the kidneys too. So anytime we're giving any two medications that may be working with the kidney, we may be competing against each other. So again, these are some straight up nursing pearls, guys. Remember these. I'm giving a blood pressure medicine. This goes not just for ACE inhibitors, but it kind of goes for a lot of our other blood pressure medicines as well. You monitor the blood pressure. You teach the patient to change position slowly. We assess for renal impairment before we administer them. We're going to give on an empty stomach for best absorption, monitor their potassium. Sometimes our African American patients are, as the JNC8 calls them, our Black patients versus our non-Black patients. Our Black patients can have an increased risk of having more adverse reactions to the ACE inhibitors than they do to other cardiac medications. And of course, we're not going to use them in pregnancy. These are our ARBs, our angio-2 receptor blockers. Again, work just a little bit differently. Kind of like what we saw in the diuretic therapy where they're working in different parts of the kidney. This is working in a different part of the pathophysiology of the renin system. You can see its uses there, and it has a really good chance of not causing the patient to have that hacky, dry cough. So if an ACE inhibitor causes them to have that little dry, irritating cough, sometimes an ARB will prevent that from happening altogether. So here's the common names for this. You'll see that they all end in the last name Sartan, S-A-R-A-R-T-A-N. So if I saw a medication come up on a test and I saw that Sartan, that would make me think about our ARBs. We can give these, again, we're looking for those same kind of things. They can cause hypotension, they can cause issues with the renal system. So we're watching for these side effects as we're giving them and thinking, if we're combining a diuretic and an ACE inhibitor, we're going to get an increased potential effect. So again, the more that I'm dumping into this patient, what am I going to cause? What kind of havoc am I going to cause? Another one of our ACE inhibitors is our direct renin inhibitors. I will tell you that we don't see these as frequently as I thought we would. They're still pretty costly because they haven't been on the market for as long as some of the other ones. So that might be one of the reasons why we don't really see these out there that much. But you never know. And as you can see, the side effects, the uses are all pretty much the same. Our aldosterone antagonists, you're like, wait, I've seen this before. Yes, you have, because we talked about these in our diuretic medications as well. Again, really great medications, will help to save potassium, but can be used to treat high blood pressure alone. How often are you going to see a patient on this agent by itself? And the answer is not very often. Typically, it's combined with another type of a therapy. If we see the spironolactone, especially on a female patient, we may be looking for some polycystic ovary disease, acne, maybe we're having some facial hair. It will help to block those types of symptoms from occurring. Okay, so because Mr. Chuck is considered a black man, when I look down at my JNC 8 criteria for prescribing medications, and I know you're not prescribing, but I would expect to see a black man who has no chronic kidney disease, whose blood pressure is greater than 140/90, and he's black, either a thiazide or a calcium channel blocker. Well, here's our calcium channel blockers. So the great thing is our calcium channel blockers come in a couple of different flavors based upon where they work the best at. So our non-selective tends to work on our blood vessels and our heart, and our selectives just work on our blood vessels. You will see references in other pharmacology textbooks to there being 3 of these. They call them CB1, CB2s, and CB1, 2, and 3. So some textbooks pharmacologically will say, okay, if it works on blood vessel and heart, it's a CB1. If it's a CB2, it only works in the heart. If it's a CB3, it just works in the blood vessels. It just depends on the way that the pharmacology textbook lays it out. We're going to go with the way that this one says. So our CB non-selective, these are going to work on both our blood vessels and our heart. We have a couple of different uses for these, not only high blood pressure, so this would totally be a drug that we could use for him, but we also use it for angina pectoris. This is the type of angina that we can predict. This is what we call stable angina. This is the angina that the patient's going to get anytime that they do work past this physical point, okay? We will also see these medicines used whenever our patients have heart arrhythmias, such as atrial fibrillation. We really don't see this one used that much for supraventricular tachycardia because it doesn't work fast enough to get the patient out of it. But in atrial fibrillation, we will see them quite a bit. Again, there's some drug interactions here. With these medications, because they're working on the heart, what they do is that when calcium goes in a cell and out of a cell, when it switches that's what causes that muscle to contract. So the calcium going from one place to the next is what causes the contraction. Well, when we block calcium from going in a cell, we're essentially kind of stunning the muscle so that it doesn't react. That would be what we'd have in a patient who's having an arrhythmia or a dysrhythmia. So when we give medications that also do that same sort of a business, meaning that they affect the way that the muscle contracts, then we can get some drug interactions, we get some potentiation, we get an increased amount of the effects that we may not want. So digoxin and beta blockers are pretty much known whenever we control that, when we can do those together, that we're going to get a bigger bang for our buck. Because of that, we may be over treating the patient. So just be watching the patient's heart rate and their rhythm will be very important for them. So you'll see some of the side effects here. A lot of the side effects of this type of medication are in relation to that calcium coming in and coming out of the cell. It says it's non-selective, and we say that we're just talking about blood vessels and the heart, but really you've got calcium that's running in and out of every cellular membrane in your body. It's not just your blood vessels in your heart. So that's why we're kind of seeing some of this side effects spill over to some other areas of the body. For instance, the GI system causing constipation, okay? So here's our selective ones. You'll notice that these all end in dipine, amlodipine, phylodipine, notocarpine, and nifedipine. These are all dipine, and they all help the patients with high blood pressure. We see these more frequently given for high blood pressure than we see them given for angina. There is some bleed over effect. They call these selective, but because they do sometimes give these for angina, there's some little work that it does with the cardiac cells, but it's not to the extent of what diltalazine would do if we were giving it. We are very cautious if the patient has a funky heart rate, if they don't have a normal electrical pathophysiology system through that heart, because if the heart's not already beating right, and then we're going to go in there and tell calcium, no, you can't fire from cell to cell to cell to cause a muscle contraction, we can hurt this patient. So we're very cautious if the patient has heart failure, bradycardia, sick sinus syndrome. They just don't have they have a funky electrical system going on. We're very cautious with these patients so that they are not being injured or hurt while taking these medications. Dang phone. Every time I think I have it turned off, I don't. Okay. So here's just those fun little slides again to help kind of pack this stuff into your brain. Helps you to remember that these are all the calcium antagonists. Whenever we give these medications, we need to make sure that we are monitoring our blood pressure before and after administration, especially in the hospital when we're starting new therapy. So when we have patients that we're starting a new blood pressure medicine on, I'm always like a mother hen, like, what's going to happen? Versus a patient who's taken the medication for a long time and we kind of know the effects of that medication. Typically, if I'm having to give this any blood pressure medicine or any medicine, IV, especially when I'm trying to affect their blood pressure, I'm like a mother hen. I watch them very closely. When I go in to give an IV infusion of diltalazine, I typically am going to give a loading dose, a bigger dose in the beginning, and then I'm going to put them on a maintenance dose. When we're giving medications IV that are going to affect the pulse and the blood pressure, checking their vital signs every 5 minutes until you make sure that they are stable is a great, fantastic idea. So I'll do it like every 5 minutes, usually for 20 minutes, and then I'll back off and I'll go 10 minutes for another 20 minutes, and then I'll go every 15 minutes for 2 times, and then I'll put them on every 30 minutes for 2 times, and then I'll put them on every hour after that until I make sure that this patient is stable, meaning that I'm not seeing like, okay, the first blood pressure I got was 159, or let's make it really impressive, 199 over 110, and the next one I got was 90 over 60, and the next one I got was 110 over 60, and the next one I got was 230 over 110. I'm not doing like this. Stable means that they're all within a range. It doesn't mean normal. It just means it's stable, meaning that we don't have a lot of fluctuation from one blood pressure reading to the next. I could predict what the next blood pressure would be based upon the trends that I have seen. This is a brief strip about atrial fibrillation. So when a patient has atrial fibrillation, their heart is not beating in a rhythmic manner. So we may have a heartbeat, and then we may blah, 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 and we may have a heartbeat, blah, 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 and so it's not, instead it's more like, it's everywhere, okay? So this is what would be known as atrial fibrillation. You don't have to know rhythm strips for your exam, but for this upcoming test, eventually when you take other classes, you'll have to know them. But I just wanted to kind of like introduce it to you so that way whenever you get ahead of you in your educational career, you're not freaking out about strips. Beta blockers. Love a good beta blocker. So a good beta blocker will prevent you from doing what just happened to you. When I yelled beta blocker, your heart went boom, 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 because you got a little frightened, right? So when we think about what our beta cells do when they have a sympathetic reaction, right? Okay, I go back to my handy dandy little chart again. Okay, I could never get away from my chart. My chart is precious to me. Okay, so when I have an agonist response, what does beta do? Beta dilates my bronchioles, it makes my heart rate increase, it relaxes my smooth muscle in my stomach, it relaxes my uterus, it makes me have more blood sugar available because I need to get it, I need to get going. Okay, it's getting me ready for that fight or flight response, right? So the advantageous here of beta blockers is they're going to decrease the heart rate, they're going to decrease the contractility of the heart, they're going to be like, man, take it easy. And they're going to reduce cardiac output and lower the systemic blood pressure. Also, a fun fact about beta blockers is we do get a little bit of blockage of renin which means that the patient is going to be able to void more urine, just a wee bit, not a lot, just a wee bit, okay? Again, we have these in 2 different generations, and let's talk about each of those generations in separate contexts. Here's your first generation of beta blockers. OLAW is your last name here that you would be looking for. If my last name was OLAW, you would think that I'm probably a beta blocker. We use these for a couple different things. You can see these are really non-selective. They're going to be affecting both our beta 1 and our beta 2s. When do we use these? We use these for all sorts of fun things. I will tell you, in the case of Mr. Chuck, we would probably be using this for like a hypertension type of episode. But because he's black, that wouldn't be a good idea. We use that for our non-black friends, but not for him. And we really are starting to reserve beta blockers for a lot more specialized therapy. Patients who are having some heart failure issues, some angina, patients who are having migraines, we're really kind of reserving the beta blockers for that usage and sticking to our ACE inhibitors, our ARBs, our calcium channel blockers to control that blood pressure. So the side effects of the medication are the same, are just the opposite of the intended use, right? Bradycardia, heart block, heart failure, and then a rebound effect. When I go to give a beta blocker to a patient, one of the first things I'm going to do is, before I give it to them, take out my stethoscope. I'm going to put it on the flesh because that's the only place it counts. And I'm going to get over here to the apical pulse, okay? And I'm going to listen, and I'm going to count their apical heart rate and make sure their pulse rate is good, okay? As long as their pulse rate is greater than 50, I'm okay to administer a beta blocker. When their heart rate gets to be 50, 55, that's when I really start to question whether or not this patient needs a beta blocker or not. Because if we put the pulse rate too low, the patient may not do as well as they should, okay? Again, we'll have decreased cardiac output, you get confusion, you get all sorts of crazy reactions whenever that happens. So with our patients who are on beta blocker therapy, check their apical heart rates before you give them the medications. Rebound effect. We have to stress compliance with medications, especially blood pressure medications. Just like we talked about with antibiotic resistance, if a patient doesn't take all their antibody doses, they can get antibiotic resistance. Something far more terrible happens whenever our patients are having high blood pressure and stop taking their blood pressure medicines. They can actually develop rebound hypertension, which means that their blood pressure gets worse because the patient is not taking their medicine. It's like all of a sudden the body's like, we're free, we're free, we're free. And their blood pressure goes really, really high. So be thinking about that. The other thing I want to talk to you about beta blockers is that sometimes they can mask the signs and symptoms of hypoglycemia. When my blood sugar gets low, my heart rate goes up, my breathing gets right, I get sweaty. Because you're taking a beta blocker, you can't have any of those reactions. They're all being blocked because they're taking a beta blocker. The other fun thing about beta blockers is because they keep the pulse under control, we may not see those first signs and symptoms that this patient's in trouble. Let me explain. When I have a patient who runs a high fever, one of the things that I look for is if a patient comes in, I'm like, yeah, I don't feel good, and I put the pulse ox on their finger. Well, if they're tachycardic, that's usually a sign that they're hypovolemic and that they've got to maybe have a metabolic process going on, something, right? Beta blockers are going to mask that. So on our elderly patients who are taking a beta blocker, they may not have the ability to have an elevated heart rate. And because they can't have an elevated heart rate, then what we're going to see is those patients may get overlooked, or we may not pick up as fast that they're sick because they don't have an elevated heart rate. So I look at my medication list. If my patient's on a beta blocker, I'm like, you're not going to get me, because I know that patient's body is being blocked. They can't have a fight or flight reaction. They're on a beta blocker, okay? So I have to look for other signs and symptoms that they may be developing an infection or have a low cardiac output, okay? So just to put those things in your brain. Here's our second generations. Our second generations should be a lot more specific and just hit the heart, okay? So when we think about beta 1s, we think about beta 1 receptors. They're usually in our heart versus beta 2s, which are usually in our lungs, right? Okay, so when I think about my beta ones, my first generations, they're actually non-selective. They've got beta 1 and beta 2 actions. So if I had a patient who has chronic obstructive pulmonary disease or asthma, that bronchial constriction that's caused by those first generation beta blockers may not be a good choice for those patients. Instead, we might want to see these patients on a beta 2 blocker. Okay, so this would be metoprolol, atenolol, Belectol, bisoprolol, acetobol, esomazole. Okay, again, they all still end in olol. They didn't help us out and change their last names here. You just kind of have to memorize the list. But with these medications in the second generation, we really get a lot more heart effects. So really targeting down to the heart, we don't have as many pulmonary or bronchial constriction effects. So because of that, these may be a better option for a patient who has heart failure, who also has a COPD or an asthma or some other lung issue. Again, here's all those wonderful side uses. We have the exact same uses for these as we did for the other ones. The side effects are also the same. Okay, and here's a fun little slide here to help you kind of put this stuff in your brain. Remember that all of our beta blockers end in olol, not olaf, olaf, olol. We also have some medications out there that are specific to both alpha 1 and beta 1s. You'll notice that one of these medications, they kind of have a similar ending to our beta blockers. With these medications, they have both the alpha 1 qualities and the beta 1 qualities, so they're going to have to cause some vasodilation, and then they're also going to block some of the contractility of the heart. Carvedilol is probably the most popular one in this drug class, and you'll see it frequently prescribed to our patients, not with just hypertension, but if they have heart failure, we'll start them on carvedilol because they do much better. They have much more better outcomes if they're on the carvedilol. We typically start carvedilol very low and slow. We'll go at 3.125, then we'll do 6.125, and then eventually we get them up to the full dosing, which can be anywhere between 25 milligrams a day and 50 milligrams a day. Alpha 1 adrenergic blockers. This is some of those big, bad, scary ones. The reason being is because they can cause pretty significant orthostatic hypotension. The cool thing about these medications is that it helps not only to control blood pressure issues, but for your gentlemen who have an enlarged prostate, it can also help them to pee better. Had a gentleman that I worked with for a long time, and he kept having these orthostatic issues. I'm finally like, let me see your med list. And sure enough, doxazocin was on his list, and he was still taking a lot of other antihypertensive. So I recommended to the physician, I said, hey, let's get rid of this one. Let's take him off the ACE inhibitor and try this. Worked out much better for that patient, that specialized hypertension therapy plan. Again, orthostatic hypotension. Patient stands up, whoo, gets dizzy. This one's really bad about causing a first dose effect. With these patients, because their blood pressure goes so low, these medications can cause reflex tachycardia. Like all of a sudden the pressure is so low that the body's like, oh my God, our cardiac output's low too. We should increase the heart rate. And so it makes the heart beat faster so it can get an increased cardiac output. So can happen. Also nasal congestion and inhibition of ejaculation. Unfortunately, any beta blocker has the potential of causing severe impotence. So please watch your male patients and have those sensitive conversations, especially when they started therapy. It can really affect their psyche if they can't get it. If they can't do that, they get depressed. The other medication that I want to talk about is essentially acting alpha-2 adrenergic agonist. You're like, wait, Ms. Hardy, I am looking at alpha-2, and when I look at alpha-2 and we're block that, it gives us a blood dilation. Yeah. So if we're having an agonist response, that constricts the blood vessels. So don't we want to have a antagonistic response? So very interesting. So your alpha-2 receptors in the base of your brain actually work opposite of what you would think they would. So with an agonist response in the brain, it blocks the blood vessels and says, hey guys, chill, dilate. And so you get a decreased peripheral vascular response instead of an increased peripheral vascular response. So with these medications, you will see that if it's given PO, it's for hypertension, We can administer clonidine via intrathecally into the cerebral spinal fluid, and it will actually be used for pain relief, but that's the only time it's ever used for pain relief. Cool thing about this medication is we have not only oral tablets of clonidine, but we also have transdermal ability. So for those patients who are non-medication compliant, maybe they get confused, sometimes applying a patch to a patient, we can apply them 1 week at a time, and it'll transdermally deliver that blood pressure medicine over a couple of days. Oh, well, over a week. Always monitor your blood pressures before and after, especially in the hospital setting. When we're in the community setting, we want to see a blood pressure log, okay? Just time, date, blood pressure, time, date, blood pressure. We want to know what this blood pressure is doing whenever we're not there. You know, we as healthcare providers, when we roll up on the scene, people get all excited and their blood pressure goes up because they're like, oh Lord, here comes that woman. She's gonna tell me something. Okay, so just we want them to keep a blood pressure. I don't care if it's a wrist monitor or an arm monitor. I will tell you, if I had my preference, they all use them on their arm, not on their wrist, because this is a radial pressure. This is up here, is brachial, is a little closer to the heart. So I'd rather have this blood pressure on the arm than I would have a wrist or even a finger pressure. But I know my patients, and I can tell them not to use a wrist cuff. That doesn't mean that they're going to listen to me. It is a lot simpler and easier to manipulate that cuff than it is to try to get it up on the upper arm. Here's the side effects of our adrenergic blockers. Again, just trying to get that kind of programmed into your brain so you can see that. Direct acting arterial vasodilators. If you're seeing nitroprusside come across your desk to give, you are working in an emergency department or you are working in an ICU. That's the only two places you should be given that medicine. It is bad for business. It can cause a lot of serious side effects. So we'll see that one more in ICU. Hydralazine, on the other hand, you will see frequently in our population of patients that we work here with in our area. We use hydralazine when nothing else has worked, okay? You'll see these patients, I've seen them come in for like hypertensive urgency. They got a diuretic, they have an ACE inhibitor, they have a calcium channel blocker, they got a beta blocker, and they still have uncontrolled hypertension. You're either going to see hydralazine or clonidine, one or the other, trying to get this patient back under control. We see some of these same side effects that we saw earlier with clonidine, we see here too. The reflex tachycardia, palpitations, headache, dizziness. Again, we tend to use these a lot in our hypertension emergencies. At the hospital, frequently we'll have physicians who'll write hydralazine 4 times a day. So you'll do a 25 tablet in the morning, lunch, afternoon, and then at bedtime. With these patients, when we give them that medication therapy, it's great. It works wonderful. The problem is that then you have to send that patient home to take that medication 4 times a day. Increased doses always leads to decreased medication compliance. So just kind of a general statement about medications and things that you should know. Anytime we give the blood pressure, before I give a blood pressure medicine, especially in an acute care setting, I want to take that blood pressure at least 30 minutes before the blood pressure and then 30 to 60 minutes after that medication. I always want to warn my patients about orthostatic hypotension. I always want to take the apical pulse if the medication affects the heart rate. And then I always want to look at, especially in the hospital, we have this luxury. Like I look at my full set of vital signs and I go, okay, so yesterday they gave us all the same medication and we didn't like wind up in a puddle on the floor or have to be fluid resuscitated. So these are always a sign that, okay, so we didn't kill them with this medication, so maybe we're going to be okay today. We won't have a significant drop in blood pressure. But anytime that you as a nurse are adding on that new therapy, my level of assessment and diligence about watching this patient and monitoring this patient is always elevated. Okay, so there's our patient's blood pressure. So what do we think we need to do in order to get his blood pressure back on track? What kind of medications do you think that this patient should take every day? I mean, there's his readings. Do we need to do anything about them? Is it something we need to do? Again, he's in his 40s now. He's working for hospital administration. What kind of teaching do you think he needs when we give those blood pressure medicines? And then what happens to Chuck if he doesn't take his medications as prescribed? These are all consequences that we need to think about. All right, guys, see you back in a few minutes for some more.